attendees have slowed down and have kind of leveled off. So good morning. I appreciate everybody joining us this morning, especially on a Friday. It's gloomy outside, but we are going to, at a high level, talk about the enhanced FMAP stakeholder process that we're going to start going through, all those funds that hopefully we will be receiving in the future. And actually, Pam will be taking us away. But first, I just want to go over a few things. So if you can't hear with your computer speakers, you can also call the number below, and then it will give you prompts through the webinar, and you can remain logged in to be able to hear if you're having any issues with that. If you are having any trouble with your connection, you can try logging in using a different internet browser. Zoom works best in Chrome, Firefox, or Edge. Obviously, Internet Explorer is not a supported browser. And then if you need any help, you can always send us a message through a private chat by clicking on the chat icon. And before I turn it over to Pam, I'll just go through the quick meeting agenda. First, we'll do an introduction. We will talk about what the enhanced FMAP is, what all those acronyms are, the spending of the enhanced FMAP. We will go through our spending plan. This will be just highlights and about the implementation at a very high level, very early in the process. So, don't think that we're going to get deep into the weeds today. We will also tell you all how you can get involved. And then we will have a question and answer session afterwards. So we do have, if you look, this is a webinar based. There is a Q&A function. So please put any of those with the, any questions you have in the Q&A. Please do not turn on, put anything in the chat, as we won't be able to see that. We will be using the Q&A to answer all the questions. And then somebody said that they heard me fine until I put on the headset. So can you all hear me okay, or is it best if I take that off?
That's better, Alicia. You got a little bit louder there.
Here, Pam actually came back in here because it looks like her computer was messed up. So here, sounds like it worked better when I didn't have anything on. So let me try to take this out.
All right. Oh, Anne has already answered that has fixed it. So that's great. I'm glad that you all can hear me. So now I will go ahead and turn it over to Pam so that she can take us away and give us all the good details.
Hello, everyone. Thank you for coming. This is our second, we're trying to fix the camera, but trying to not drop the computer as well over here. So I apologize for the technology challenges we're having this morning, but this session is really meant to be a very high level overview of the enhanced FMAP and what our approach is going to be. There will be many more sessions beginning after the new year starts, many more opportunities for stakeholder engagement and participation. I'm going to go to the next. So first, to talk about what is the enhanced FMAP. So the federal government matches every dollar that Kentucky spends on the waivers at so for about every cent, 70 cents of the dollar is federal funds, and 30 cents, the other 30 cents is made up of state funds. The American Rescue Plan Act that passed this spring gave a period of time for that FMAP to be increased to an additional 10%, and we're able to take those that additional funds, reinvest it into the waiver, and do things that enhance the waiver and strengthen the waiver for the individuals. We submitted our initial spending plan and narrative, and that was partially approved by CMS. We estimated that we're going to receive several $1,000,000 in the additional federal funding, but the amount varies based on how the money is spent, as well as how much money we spend. So just for an example, if services that are benefit services, so like your any payments for services, those are matched. We get a federal match of 75-25, and services that are administrative, so the foundational pieces we have to run the waivers, those have a lower match rate. That's at a 50-50%. This money, it was not drawn down in one lump sum, so we have to report quarterly and have the opportunity to draw down the funds quarterly. So we have done our initial drawdown of money to begin starting some of the initiatives, but it's important to note that we did not get a lump sum all at one time to have just this pocket of money for us to spend out of. We have submitted the additional questions, answers to those to CMS, and we are waiting on final approval. We also have submitted the first quarterly report, with the next one being due actually pretty early in January. So to look at kind of how we divided the money, or how the percentages, what we were going to do, you'll see the highest one goes to workforce development. That's going to include tasks such as retaining staff, hiring staff, recruiting, developing career ladders, enhancing training programs, looking at talking to our vocational schools within the high school, as well as some of our colleges for developing a direct support professional track. You know, a lot of times if you're in high school and you're in on the health services track, you can get your CNA certification before you graduate. But and a lot of people equate being a direct support professional or a DSP with being a CNA, but it's really different in that, you know, these workers are helping individuals to achieve their goals, to be integrated into the community. Yes, there are very intimate parts of their life that they are involved in. They help with personal care, but they become much more than an aid to that individual. A lot of times they become friends and family just because they are as invested in an individual reaching their goals as the individual and their family. The next biggest spend is looking at improving the ease of access to HCBS. So that will be where the rate study will come into play, our review of services. We have to have a rate study so that we can, you know, prove to CMS that we have a documented, solid methodology for how our rates are determined, and that we do not have or how we are going to address the existing disparity for similar services based on different waivers. Crisis services, so we're looking there at how do we do maybe exceptional supports in more than just SCO waiver? How do we facilitate when an individual has an event, whether it be a mental health crisis or a physical health crisis, and they need to go to you know, they have an extended hospital stay and they maybe need some additional assistance to transition back out into community, into more independence successfully. And then the two last pieces are the tools and transformation and project support. So we will have a consultant group that will that you all will be introduced to in January once contracts are finalized. But that helps us just to make sure that we have adequate, you know, that we don't miss any reporting dates to CMS, that we maximize how we draw down the funds. They also will be conducting the feasibility studies, looking at the potential to add a couple new waivers or modify our existing waivers. And then tools and transformation, that's going to be looking at how do we continue to enhance MWMA to make it more user-friendly, as well as what other technology would be beneficial to support our individuals to be as independent as possible. So I talked a little bit about this in already as I talked about the workforce development, but looking at, incentive and recovery payments to help provider agencies. So, COVID has been very difficult, but in reality, if we go back, even before COVID, states were talking about retaining employees. So it's been a problem for a while. We realize that it is critical you can't add services or change services if you first don't address the workforce issue. Looking at better training for the DSPs, as well as training of our participants and the individuals that help them with PDS. Looking at things like a system where they could come in and could take certain courses, and that would give them recognition, so they have a badge that they've done so much training in, say, someone that has dementia, so on the care of that kind of individual. So looking at that, looking at the looking at career advancement. So really, how do we make the DSP role become a career ladder for an individual? It's an important job. How do we explain to people what the job is? So, this would include talking to schools, talking to at job fairs, and really helping to advance that career and help individuals understand what an excellent opportunity it is for being a career. We're looking at creation of a central employee registry. What this would be essentially is, if you can think of it like an Indeed or a LinkedIn, we're in the initial stages of research right now, but the theory behind it is that an individual could come in and say, I live in Franklin County. I'm interested in providing services in, Franklin, Fayette, Anderson counties. This is my experience. These are the hours that I'm available, or that, that interest me most for working. And then traditional providers and our participants that want to PDS services would have access to that, and they could go out there when they're looking for employees to fit particular needs. So it would assist with onboarding. There would be ways that, background checks and trainings would be held in this central repository, so they become more portable, and it's not as difficult to onboard. Say if you want to work for a couple different participants, or even you want to work for a couple different agencies, that information would be available to both of them. Sorry, having technical difficulty. There we go. Improving ease of access to HCBS. So I talked about the rate study and the review of our service menu. One thing that is important to talk about here is that part of us receiving these funds is there are multiple assurances that we have to make to CMS. So I want to ease everyone's mind when we talk about rate study to say that the rate will not decrease. We as a one of the assurances and us receiving the funds is that we have to commit that rates will be no lower than what they were on April 1st of 2021. So rates will not be decreased. Services, we have to guarantee that we are not making it any more difficult or taking away services that individuals already access. You will see some change of services for example, there are some that are available in state plan now that may take the place of the waiver service, as well as in a couple waivers, there were some services that were listed in the waiver but did not get included in the regulation. So they actually have never been a part of the waiver, have not been received by anyone. So we'll be doing that cleanup really to have the service menu correct to where we are right now. The HCBS waiver waiting list, right now we have 2 waiting lists, SCL and Michelle P. We're going to be looking at how do we possibly implement an emergency process for the Michelle P waiver. What can we do to get services to individuals that are on the waiting list, even if it may not be through the waiver? What can we provide through state plan? Because actually over 70% of the individuals that are on the waiting list have Medicaid eligibility already. So they could be accessing some state plans. So there'll be concentrated efforts on how to connect those individuals to those resources. We're looking at a no wrong door approach and some changes to the initial application process to help identify things like some of the social determinants of health, like food insecurities or need of assistance with utilities, so that we'll capture that information so that it can be shared with other agencies, or the applicant can be connected to those agencies to get help for those needs now, not just waiting until they become a waiver participant. We will be setting aside a pot of money to cover the cost of background checks for PDS employees while we're seeking a long-term cost solution. And part of that includes issuing a RFP for a financial management vendor for participant-directed services. So that would be, anywhere from 1 to 3 agencies that would handle that task of PDS across the board, just to ensure I'm sorry, everyone, that it would ensure everyone has the same delivery of the services. It would free up some of our current ads and CMHCs to do additional case management. It also would allow us to put into that rate coverage for those background checks. Crisis services, I initially spoke about a little bit before. The Department of Behavioral Health has already been working on the 988 initiative. So it's creating a 911-like service for when you have a mental health care need versus a physical need. We'll work in conjunction with them. We're also working in conjunction with our behavioral health state plan services to look at mobile crisis. We have some grant dollars there that we're looking at. How do we implement that? How do we look at crisis care management? How do we look at crisis respite? And as I mentioned before, crisis can be a mental health crisis, but it also could be someone that all of a sudden has lost all of their caregiving support and they need immediate care, or, they've had a fall and maybe broke, multiple bones, and they're going to need a little more help transitioning back into the community. So it's implementing those types of services in all of the waivers. So tools and transformation, one of the things, telehealth has been a very important tool during COVID. We will be making telehealth permanent, not to the same extent that we've used it during COVID and continue to use it during COVID, as, sometimes it's important to have eyes on individuals, because, for example, someone can tell you, oh, I can, I'm not having any trouble walking, or I can do my bath without any problem. Yes, I have enough food in the home. And when you're on the phone and you just see them on a screen, that may look correct to you. But if you're in the home, you may see them holding on to everything to walk from, a chair to a kitchen table. You may see that there's really not any food in their refrigerator. You may pick up on, smells. So it's very important sometimes to be able to pick up on other cues than just what someone's telling you. We want to increase the availability of assisted technology and remote monitoring to let individuals live in less restrictive settings. I mentioned earlier the feasibility study to determine if waivers can be reconfigured or added to serve additional population. That's going to include looking at an SMI and an SCD, so serious mental illness and severe emotional disturbance, looking at those two populations, looking at our medically complex individuals and looking at our children to see, is there a way that we can serve them differently, or do we need to explore the implementation of new waivers? The implementation of PACE, or the Program of All-Inclusive Care for the Elderly, has been in process for several months, and we actually are close to doing a pilot, I believe beginning in January, of a few counties for that program. So we may or may not, you may not hear as much about that as we continue to talk about the FMAP, just because we've gotten further along in that process. So as I mentioned, we received partial approval to our spending plan that we submitted to CMS on September 30th. They requested some more information on a few of the initiatives, the transition services for individuals involved in the criminal justice system, coverage of one-time expenses to increase participant independence, the implementation of an improved application process, how we plan to conduct the rate study, and how we were using the funds for PACE. We have submitted the responses to CMS for all of those and are just waiting on our final approval. So what do we need to do next? We've provided the information to CMS, so we're awaiting the response. We have been, over the last about 6 to 8 weeks, have been developing the initial project plans for each of the steps. Our internal teams, which includes individuals from Medicaid as well as Dale and BDID, are co-leaders on projects. So work has begun on research. Some of the initiatives you will see really taking off in January. We anticipate the rate study, a lot more information to be shared about that in January. It's also important to remember full implementation is going to take some time. We know changes need to be made, but we want to do them correctly. Some of them require us to update our waivers with CMS. Some of them require administrative regulation changes. Both have a specific process for updates, and both include opportunities for public comment. So how do you get involved? We've shared, I think, and I don't know if it has been posted yet, but if not, it will be posted so that these links are live. But how, you can stay informed by emailing Medicaid public comment, signing up to get email updates. We always ask for feedback. We have a couple different links there, ways for you to do that, as well as there's links to our initial spending plan and our approval letter. I wanted to take just a few minutes before we open up for question and answers to talk about the disaster response. We have been, since Saturday, have been assessing the number of our participants and providers affected. We've had multiple staff from us and both of our sister agencies reaching out to members, reaching out to providers, reaching out to PDS employees to find out, what do you need? How can we connect you to resources? We have submitted an Appendix K to CMS that's specific to the natural disaster. So as soon as we receive our official feedback from them, that will be posted and will be sent out. But an example of some of the things that we're going to do there is we're looking at expanding, for example, counseling into all of the waivers, as we realize that PTSD is going to be a real consequence of these storms. And so we want individuals to have access to what they need to support them. We're looking at how specialized medical equipment and minor home adaptations can be expanded. We're made a couple changes to home delivered meals, as well as we are credentialing another provider as I speak today. So we'll have another provider on the ground to help with home delivered meals. Been really working with our emergency management services with KSP and the National Guard. They have given us contacts so that our individuals, because the individuals served by our waivers and served in the aging programs are some of the most medically fragile and complex. So they have given priority to doing health, safety, and welfare checks for us. We also are looking at individuals that have DME that would need power to operate, that may need, for an example, need incontinence supplies replaced or feeding supplies replaced, identifying them, reaching out to them, and facilitating that. We've had our pharmacy program has been working, our pharmacy director, Dr. Ali, has been working with the pharmacies in the area to determine who is operational, as well as giving flexibilities to make sure individuals have access to any medication that they need. As well as our MCO have also been instrumental on the ground with the population, with our MCO populations. Okay, so now we'll switch to the Q&A portion of the session. So if you have questions, we just ask you to type them in that Q&A box there, just to open that up, and we'll begin answering those questions. The video setting that blurs the background, there I believe is a, actually someone has answered that. Laura answered it in the chat on how you're able to do that.
I don't know.
Oh, okay. So we can actually, yeah. So Laura, if you want to, we can paste it in there, those directions. But really there's a video option, and you can go in and it gives you a way to either blur the background, or in some cases you can choose a picture. I know Commissioner Elridge with Dale yesterday said, it's been a very emotional week, and she decided the beach is her happy place. So yesterday she had the beach behind her. So that was, it helps sometimes, I think, when you have that. But there's some neat video functionality that we never knew existed out there. When do we anticipate releasing the RFP for financial management? I don't have a date yet. It's something that there'll be more information that's shared. We also may issue a request for information, kind of that initial thing that goes out before an RFP as well, to kind of gather some information. We want to make sure we get it right. So that will be forthcoming in the new year. We'll get more information out about that.
And just as we're waiting on questions to come in, I just appreciate all of our participants, family members, advocates joining us. This is our second webinar. We had one last night, and we had quite a few people on that. I know sometimes it does work better for individuals at night, and we received really good feedback on having those, just because, not everybody can join when it's, a 9 to 5 type of schedule. So we do appreciate you all joining us today. And like Pam said, we're here to answer any questions. We understand this is very high level. As we are moving forward and getting into it, there will be lots of opportunities to get involved.
I'm very excited for what's to come. And I will say we'll have these, the recorded sessions will be out there. So if you wanted to listen to last night's session, you'll be able to do that. I have never been very well at being scripted, so I'm sure I used different phrasing last night than I did than I did today. I tried to stay as close to the same as last night's, but you would be able to go back and listen to that session as well, and any of those questions that came up in that session that we answered. And then I believe our provider one that's a little bit later this afternoon. This question about the what kind of format the rate study will take. The last one was very tedious and difficult. I don't have the exact answer of what the format is going to be. However, we learned from some of the difficulties from the last rate study, as well as, we're not going to throw out all that information. We collected a lot of good information from providers during those studies. So we will use that, but they will be definitely more information about rate study coming early in January. So we'll be training be included for the frontline workers of HCBS Medicaid call workers. Currently, we are told incorrect information call after call. Yes, so part of the training initiative is we're not looking at just what training we give to DSPs and, provider agencies and, participants or, their families. We're looking internally as well. How can we strengthen our ancillary partners, and how can we make sure that individuals know how to connect people to the right area, and so that we really avoid. I hate ping pong phone calls more than anything. So we're really trying to build a resource too that somebody can have. We've gotten away from having the, when I first started working with Medicaid, we had this massive flip book that we would have on our desk that, literally you could go through. So now that we're more tech savvy, so we're developing places where online they can go and say, okay, this is the question somebody has. This is the next steps of what I need to tell them to do, or this is, who I need to refer them to.
And we are also looking at, even with our sister agencies and like DCBS, that is one of the things that we hear the most is DCBS says to call Medicaid. So we're looking at trying to give them and provide them some information as well. One thing I will tell you, because I do get involved in some of those cases where, because we don't like Pam said, we do not like people being bounced around. So sometimes I will go to their management and say, hey, can you just review this? But one thing that I have been told that might work for our family members, advocates, and participants, when you do call DCBS, tell them you're calling about long-term care Medicaid. A lot of times if they just hear waiver, if you just say waiver, they automatically think that you need to come to us, even if it's about financial eligibility. But long-term care Medicaid is kind of a key word on that. So just kind of a tidbit, hopeful information for you all if you ever do have to call them. And we will be training, like she said, not only our internal staff, but providing this information to our sister agencies as well.
The next question, could you touch on how you see this improving the home and community-based waiver for older Kentuckians in the 1915 C waiver? My first answer to that is that their rates would be on par with any of the other populations. HCBS, unfortunately, has some of the lowest rates. Also looking at how can we address some of the needs that we see for this population related to, I think we've made some great improvements in home delivered meals, but I see technology and remote monitoring really being a benefit to some of the individuals, both for assisting with, medical appointments. And we've looked at some really interesting and had some conversations about remote monitoring that I can remember when my grandfather had first got his pacemaker, and he had this device that, he'd plug into the phone and put his fingers in. And so, it would allow the doctor to check on, his pacemaker function without him having to come to the office. now some of the technology is unbelievable. It can determine, someone's normal gait, and it can, if someone potentially has fallen, we can have medication changes for the things for medication where, you can set things up that it will, provide the reminders and distribute the medication. And I really am excited to see some changes to the HCB waiver for, in particular, our medically fragile and older Kentuckians, just because there hasn't been a lot done in those waivers in many years. The questions have kind of slowed down again. We'll it's a time check.
It's 11:40.
Okay. So, we're scheduled to go to 12. I don't want to hold you hostage. I know, many of you have other appointments or have other things that you may need to do. So we'll stay on. We've just got another question. But if you feel like that you've heard what you need to and you want to drop, please, feel free to do that as well. Prior to COVID, Medicaid was looking at pay increases for HCB PDS employees. Will this allow for that, since McDonald's and Walmart pay $12 to $14 an hour starting out? Not only does COVID make finding employees difficult, but people will not do this very difficult job with below standard pay. And you are absolutely right, Mike. This is one of the hardest jobs. And you truly are involved in some of the most intimate activities of an individual's life. I was going back, we are part of a national direct service worker collaborative where almost, I believe, just about every state in the nation is represented on this collaborative. And we're looking at not only the rate, we understand that the rate is going to have to increase, but in some cases, we found in other states that didn't make a whole lot of difference. So we're looking to it, non-financial ways. What else do we need to do to make the job more enticing, to really hire individuals and then retain individuals? So pay absolutely is going to be one of the things that we are going to have to address. Our HCB PDS population, I believe the max rate they can pay individuals is in the $10 range. We also are working on some ways that we possibly could address that disparity in the HCB even before the rate study. So hopefully I'll have some good news about that in January that I'll be able to share, that we're able to go ahead and at least give some immediate change for HCB PDS.
And as always, if you all have questions after the webinar is over, you can submit them to us. You can always call our 1915C help desk to ask questions. You can email, or if you want to email Medicaid public comment. We try to have several different options for you all to use because we want to answer as many questions as we can to make you all more informed. And I appreciate you all bearing with us today. Normally you all do have the amazing Kelly that leads our webinars. She did have to be out briefly this morning. So that's why you got stuck with me. But hopefully we got the hearing piece fixed quickly when I took out the device, and you all had a good session, and hopefully you've learned some stuff. And as we close, like Pam said, we'll be here for a few more minutes. I know we don't have any open questions right now, but we appreciate all of you, everything that you do in supporting the people within the Commonwealth, and especially for joining us on a Friday, a gloomy Friday at that.
Yeah, and I will say too, and I mentioned this on last night's call, and we'll again mention it this afternoon on the in the provider session. If you know of anyone in the Western Kentucky area that needs help or that you need resources, we've been posting updated resource list, but reach out to us. We have. I believe, made our initial round through at least making one phone call to all of the individuals and providers that were identified in what is now up to, I think, 23 or 24 counties that either had significant storm damage related to the tornadoes or had confirmed tornadoes in those areas. So as we continue to monitor the National Weather Service website, because it has, we've had to add counties twice now as they continue to do their survey. So we're monitoring that, and we, each time more counties get added, we go back and pick up those individuals and reach out to those individuals and the providers. But if you all hear of anything or know of any needs, if you will just reach out to us in one of the many ways that you have, either public comment or the help desk mailbox, the help desk number. I think most everybody has my email address, or any of the team that you interact with daily. We appreciate that. It has been very humbling and very heartwarming to see how the individuals in Kentucky have stepped up and stepped out to help each other. Amy, I may need a little more clarification on your question. So, talking about individuals that are told they are being put to bed. Sorry, I cannot talk you all this morning. They are being put on a wait list. Are you speaking specifically about Michelle P. SCL, or on a wait list to they've been approved for? Okay, specifically Michelle P. So, we are looking at what we can do, looking at multiple ways to address the Michelle P. Wait list. We just did another allocation of, and I'll have to look to Alicia. Do you remember?
I think it's right at 150.
We've been allocating off the wait list about every 90 days. We are now close to our, we may be able to do one more round of allocations after this group is processed and we get all the responses back. But we are looking at ways to address individuals getting served either on other waivers, being served in, having needs met in other manners, or part of those feasibility studies about the waivers, including one about children, will hopefully address some of that as well, since more than 70% of the individuals on the Michelle P. waiting list are children.
And they can currently, if they've already got Medicaid, they can currently get all their therapies they need through state plan, possibly the behavior supports. And I know that I have connected some people to like private duty nursing. So for people that are on the Michelle P. waiver wait list that have Medicaid, we, if we're reached out to, trying to find different avenues of ways to help them through things that are already available in the state plan.
Yeah,
we can do that as well.
Right. School-based services, and for individuals that aren't eligible for Medicaid, looking at, are they eligible for K-CHIP benefits? Some of the individuals that are children that have, parents that have private insurance, they may be eligible for the KI HIP program, which I will not say what the acronym stands for because I will get it wrong, but essentially it pays those, it will pay the premiums on the health insurance, reimbursed for those for sometimes the entire family, to help facilitate keeping that private insurance and having benefits access through private insurance. Currently, if a participant needs hospice and waiver service billing is an issue, is that something that will be worked on? Absolutely. There's a letter that's going to be coming out to both waiver providers and hospice agencies clarifying the how the services can exist together. And we have been working with our MMIS vendor to lift the edit to prevent the billing issue. So we're still, we thought we were there, but we hit another edit that we're looking at what we need to do to get that done. But that would prevent you from having to submit claims for us to override. You would be able to submit them directly through the MMIS. So we're working on that, and hopefully, I'm hoping actually by the end of this month to have a resolution to the billing portion of that.
I'm going to give that statistic right there.
Yeah, so for 2000 or in year 2021, we actually have allocated 967 individuals on the Michelle P. wait list. So we'll give it just a few more minutes. If someone has questions, I don't want to make you sit here and look at my very tired face. But I do appreciate you taking out the time of your day to listen. I want to assure you that there is more information to come very soon. We are committed to, you know, I had said when I began this job that one of the things that I was absolutely committed to was transparency. So we want to make sure that, you know, we share as much information as we can, and that we, you know, really involve stakeholders as much as we can in the decision. It's really easy to sit, you know, behind a desk and think that an idea sounds good, but you really need to hear from the people that are operationalizing that and that are experiencing the needs to validate that, you know, yes, that is a good idea, or no, you really got that wrong. So I'm very committed to stakeholder engagement continuing. Hopefully, COVID is going to go away, or at least to the point that we can get back out there and can start seeing people face to face again. This has been the hardest part, missing, you know, traveling around the state to get to speak to people and see people. So,
And Heidi, we will be posting the webinar out there on our website. And I will get with Kelly. Like I said, she normally does and starts the webinars, and she does all of our communications and our posting. But I will ask her if she can possibly send out that link to everybody that's registered. She should have those emails. However, it will be on our website, and I'm not sure for our family session. I'm not sure if it'll be last night's or today's. They'll probably take a look to see which one's, I guess, the best, or she might just say any, mini, miny, mo and pick one, but it will be posted out there.
Do we still have slots open in home and community-based waiver, and will they expand the number of slots after the enhanced FMAP? So we still have, I don't have the exact count in front of me, but we have several thousand, I know at least a couple thousand slots in HCB that are available. Expanding slots is tricky with the enhanced FMAP because you have to be able to sustain anything you implement once the enhanced FMAP goes away. We did include in our budget request, we have asked the legislature for funding to add slots to those waivers that have waiting lists. I'll just put the plug in here. You know, every time I go over there, I think that actually Senator Meredith probably just expects it to come out of my mouth at this point. I tell them, you know, show me where the money tree is and I'll go shake it. But you know, literally we need their support to to give us funding to be able to make changes to these waivers. The waiver redesign task force actually just concluded this week, I believe. See, Wednesday, I think was the last meeting, and the recommendations were all put forth, and so I believe they're out there, should be out there on the website. I can ask Kelly to post those if you haven't seen them, but there were a large number of advocates, provider agencies, and individuals that testified as well about how important the funding is. So talk to your legislators, make sure they remember we need money for these programs.
We do have about 5 minutes remaining if anybody else has any pressing questions.
Amy, will you, I just saw your note about KHIP. Will you email me directly some information and let me check on that, for you? Let me know if you need my email address, or if somebody will post it in the chat. So I guess we're close to time now. If you are like me and think of something immediately as soon as you hang up, oh, I wish I would have asked that, please reach out to us. If we don't speak to you again before the holidays, happy holidays, Merry Christmas, Happy New Year. And I'll steal something from the secretary that he's been saying to us. We really hope that 2022 becomes a boring year, because 2020 and 2021 have certainly given everybody a run for their money. So we're hoping for a boring 2022. But please enjoy times with your family and stay safe and have a blessed holiday. Looks like we're good. Yeah, you all can tell Kelly the next time that you all are able to interact with her that we try really hard, but we really need her. So
we absolutely do. Technical issues all over the place. We want to be respectful of everybody's time. And like Pam said, happy holidays, Merry Christmas, Happy New Year. And I will be ending the webinar now. And have a great day.